afternoon, everybody. My name is Gaurav Sharma. I'm a consultant orthopedic surgeon at MGM Group of Hospitals, Navi Mumbai. First of all, I would like to thank Dr. Vaibhav Bagaria, Dr. Ashok Sham, and Gawali sir for giving me this opportunity to speak here. So the topic is real stuff, what actually works in the sphere of orthobiologics. Now, the outline of this particular talk would be, first, the definition. What are orthobiologics? How do they work? Clinical applications, and the present evidence. Now, coming to the definition part, orthobiologics are these are the biological agents which are applied to musculoskeletal injury to alleviate the pain and facilitate healing process. Now, they can be broadly classified into four main types. First comes the bone grafts, which comprises of autologous bone graft, allografts, demineralized bone matrix, BMAC, and bone graft substitutes. There could be stem cells, which could be adipose tissue preparations, BMAC. There could be blood cell preparations, primarily comprising of PRP and PRF, that is platelet-rich fibrin. It could be leukocyte-rich or leukocyte-poor. There could be viscosupplements and scaffolds like hyaluronic acid, autologous chondrocyte implantation, MAST, and MASI. Now, coming to the properties of orthobiologics, as we know that the bone grafts are osteoconductive, osteoinductive, as well as they have an osteogenic potential. Whereas the bone marrow aspiration, that is the BMAC, they have osteoinductive and osteogenic potential primarily. And the platelet-rich plasma is osteoinductive and osteogenic. Now, one should go back to the basics, which includes the phases of wound healing: inflammatory phase, proliferative phase, and the maturation phase. So this is very important to see what pathology we are treating, whether it is a soft tissue or whether it is a bony pathology. Now, coming to the bone grafts per se, as we know, the autologous bone grafts are gold standard. Allografts are used as a space fillers and structural struts. Demineralized bone matrix are nothing but allograft minus inorganic materials, and thus they are osteoinductive and some osteoconductive properties. Substitutes, they are osteoconductive, includes calcium sulfate, calcium phosphate, tricalcium phosphate, and hydroxyapatite crystals. And they have shown wonderful results in various non-unions and delayed unions, basically in bone healing. Cell therapies comprises of BMAC, which is bone marrow aspirate. Bone marrow basically consists of hematopoietic and mesenchymal stem cells, and the mesenchymal stem cells have the propensity to generate osteoprogenitor cells. Then they can form the osteoblasts, the growth factors, which promotes angiogenesis. Now, it's interesting to see that the aspirate of BMAC before concentration has approximately 6,000 progenitor cells per cubic centimeter, which can increase up to 2,500 after the concentration is made. And as we know, the ideal and the best site is iliac crest, which can give up to 900 cells per mils, and tibial metaphysis has the lowest, which can give up to 32 cells per mils. And the good part is it's FDA approved. So coming to BMAC, it is primarily used for focal chondral defects, post-traumatic osteoarthritis, tendon repairs. We have level 3 and 4 evidence which states that BMAC is better in cases of non-union when used as an adjunctive with allograft versus autologous bone graft alone. So, however, there are a few factors which are variable, which could be location from where the BMAC has been extracted, age of the patient, sex, and comorbidities. Now, it has a wonderful synergistic effect when used with PRP, hyaluronic acid, and collagen matrices. And it is easy to harvest and use, and it's just the localized pain which is the commonest side effect for BMAC. Now, the present evidence for this. Now, this was a systematic review which was done on the concentrated bone marrow acetate for treatment of chondral injuries and osteoarthritis knee. Now, majority of the studies for the orthobiologics are done on osteoarthritis knee. They concluded that there still remains a paucity of high-quality studies. But, however, BMAC is a safe procedure and have shown to have good results. Now, coming to adipose tissue derivatives, these are nothing but mesenchymal stem cells which have the propensity to generate osteogenic, myogenic, and chondrogenic tissues. They are simple to process. They could be harvested from buttocks, thigh, abdomen, and can give up to 100 to 1,000-fold higher concentrations than bone. Now, the present evidence for this. Use of adipose-derived orthobiologics, this is a narrative review, which states that still there is low-quality evidence because of heterogeneity And this is because there has been inappropriate or inconsistent reports, injection characterization with cell counts, injection technique, and post-procedural rehabilitation. Now coming to viscosupplementation, which is one of the most commonly used thing, Synvisc, hyaluronic acid. These are nothing but high viscosity polysaccharide produced by B cells of synovial membrane. They have wonderful mechanical, analgesic, anti-inflammatory, and chondroprotective properties. It includes Hyline GF20, which is Synvisc, or Synvisc 1, which is a single dose injection. Now, sodium hyaluronate and hyaluronate. Now, this is a chart describing the ideal indication, the probable indication, and the no indication for the viscosupplementation. Now, the present evidence states that the ideal indication would be moderate or early osteoarthritis, may be of hip, knee, shoulder, ankle, or hand. Possible indications could be chondroplasty, femoropatellar osteoarthritis, advanced osteoarthritis, but only in knee. Advanced hip, shoulder, and rotator cuff tears and capsulitis, this has no role. Now, there was a study by Bhadra et al. And colleagues, and what they did is they did a survey amongst the sports physicians, amongst the orthopedic surgeons, physiotherapists, nurses, and they came up with these clinical scenarios, these 8 clinical scenarios. So what they reckon is that viscosupplementation are appropriate if there is a symptomatic adult with mild or moderate osteoarthritis who has not received any other therapy, who have failed other therapy like pharmacological or non-pharmacological therapy, who have had incomplete response, but still the response is unclear or the evidence is unclear regarding patients who have mechanical issues like meniscus pathology, adverse reactions, active inflammatory, and synovitis of knee. So again, the present evidence, how many injections are enough for viscosupplementation? So this was a study by Dr. Parag Sancheti et al. And this systematic review and meta-analysis suggests that overall 2 to 4 injections are adequate. Now, coming to the efficacy, US approved efficacy, they state that these supplements are effective for around 26 weeks in patients with symptomatic osteoarthritis. This is again by American Academy of Orthopaedic Surgeons. They say that there is a moderate evidence for use of hyaluronic acid. Now, coming to the blood-based preparations, which is platelet-rich plasma, first emerged in 1970s for hematology and then OMFs, very popular since past 2 decades. And the indications include, it is not a panacea, and you should have a thorough discussion with the patient. Usually it is USG guided. VAS score should be 4 out of 10 minimum. Non-respondents to NSAIDs and therapy for at least 3 months. No NSAIDs and steroids should be given 2 weeks prior or after the procedure, and should not be given in the presence of joint processes, active infection, or arthritis advanced. Now, this is the mechanism of action. The platelet releases various factors which triggers the healing cascade, and this is the process. Now, coming to the working PRP, I'm sorry for the time. Coming to the working PRP, now working PRP is if the platelet concentration is 10⁻⁶ per microliters and mils in 5 mLs of plasma, then that is called as working PRP. Anything below this and anything more this, the evidence is inconclusive. It also consists of,
I think we are short
platelets,
of time.
Yes, sir.
Can we just wrap it up fast?
Yes, sir. So, now we have seen that there is an upsurge in the studies for PRP, and the evidence still remains controversial. So where should I inject? There are various tendinopathies. For rotator cuff, only 24 weeks improvement and no functional improvement. Lateral epicondylitis, yes, definitely better long-term results. Ulnar collateral ligament injury, only in partial tear there is a good result. For patellar tendinitis, for tendoachilles tendinitis, ACL tears, meniscus tears, plantar fasciitis, no, the evidence is still unclear. For muscle injuries, maybe single injection is the way to go. Now, this is a diagram showing, there's a picture showing difference between the PRP and the PRF. Now, PRF is something which is second generation and is a better molecule. And now, this was an interesting consensus of the American Orthopaedic Journal of published in Orthopaedic Journal of Sports Medicine. So they state that for focal injuries, there is lack of evidence. The only take-home message for this is that PRP is the hero. So PRP is the way to go. And a recent survey was done of American Academy of Orthopaedic Surgeons, which again states that low leukocyte poor PRP is better for osteoarthritis, whereas leukocyte rich PRP is better in case of tendon pathologies. So one should remember that one size doesn't fit all, and we should have a tailored approach. To summarize, the bone grafts are good for bone healing. Stem cells, ATDs and BMAC are good. Equivocal results, good adjuvant. Viscosupplementation, moderate evidence, but still one of the most commonly used ones. Blood preparations, PRP and PRF. So leukocyte poor in osteoarthritis and leukocyte rich in tendon pathologies. Thank you.
Thank you.